Hi friends, today we are going to discuss about biomarkers in the ICU. So, biomarkers are measurable indicators of biological states or conditions that can be used to assess normal or pathological response or pharmacological response to therapeutic intervention. These biomarkers aid in the early diagnosis, risk stratification, monitoring the response to treatment, and guiding the clinical decision making. Commonly used biomarkers include C-reactive protein, procalcitonin, beta-D-glucan, galactomannan, lactate, troponins, brain natriuretic peptide, etc. And these are effective. Uh, their effective use requires understanding biomarker kinetics, specificity, sensitivity, and interpretation within the clinical context. When used appropriately, biomarkers can enhance diagnostic precision, optimize treatment strategy, and potentially improve patient outcomes in ICU settings. So first of all, let us discuss about C-reactive protein as a marker of infection for ICU patients. C-reactive protein is synthesized in the liver. Its synthesis is stimulated by production of IL-6, IL-1 beta, and TNF alpha. These are the markers which are present in any kind of inflammation. The response is rapid and the levels increase within 6 to 12 hours after stimulation. Peak levels can reach up to 1000-fold within 1 to 3 days. CRP increases in various infections, more so with bacterial infections. It can increase very high level in severe infections. However, it can also increase in other inflammatory conditions like severe trauma and myocardial infarction. There are various systemic illnesses which can lead to rise in CRP, and these include cardiovascular, gastroenterological, rheumatological, nephrology, and neurological conditions. Diagnosing sepsis is always challenging because the symptoms are non-specific, which include fever, leukocytosis, and tachycardia, and the culture positivity comes less often than we would like. Also, there are non-infectious clinical syndromes which can present with sepsis-like symptoms. Body temperature is also a useful marker. So if it is high, we can definitely say that there is infection, and if it is low, we cannot rule out infection. So in spite of being inexpensive, reproducible, and non-invasive, it is not the best of the markers. Also, we need to keep in mind non-infectious causes of fever. If we see the evaluation of CRP versus temperature versus WBC, we can see here that CRP had the significantly higher area under the curve compared to temperature and WBC, which makes it more reliable than the other two. When we see CRP and temperature individually, they have a fair sensitivity and specificity. However, when we combine them, the sensitivity remains less, but there is 100% specificity. So, combination of CRP and temperature elevated increases the specificity to a very high level for diagnosis of infections. Now, as the level of CRP rises, you can see from sepsis to severe sepsis to septic shock, the level keeps on rising, and it gives you some idea about the severity of infection as well. So to conclude, CRP is a better marker of infection than temperature and WBC in critically ill patients. Combining CRP and temperature increases the specificity to 100% for diagnosis of infection. CRP levels correlate well with sepsis SOFA score, and clinical application of CRP with temperature strongly supports the diagnosis of infection. Now we will discuss a little bit about procalcitonin, which is a widely used biomarker for infection in ICU. So why PCT matters? So we all know there is antibiotic overuse, and many respiratory illnesses are viral but still treated with antibiotics. Overuse leads to development of multi-drug resistant organisms, and use of PCT also helps to shift from fixed doses to personalized therapy of antibiotics. If we compare PCT with other biomarkers, PCT is more specific for bacterial infection compared to CRP and WBC. It has got superior prognostic value for bacterial infection treatment, and there are excellent profile for tracking infections response to treatment. There are various clinical trials which have shown that PCT reduces antibiotic duration by 2.4 days in respiratory infection. It led to 30% decrease in antibiotic prescription at the initial presentation, and it also significantly reduced antibiotics related costs without compromising on patient safety. Also, since there was less use of antibiotic, the side effects were also less. There was lower incidence of Clostridium difficile, and there was decreased development of antimicrobial resistance in the monitored pathogens. This eventually led to lower mortality in PCT guided patients, reduced ICU length of stay by 1.3 days average, and no increase in infection recurrence or treatment failure or hospital readmission rates. So this was across 6,700 patients, and PCT proved to be a safe marker to reduce the antibiotic use. How do we use PCT in sepsis management? So PCT, following PCT based algorithm led to earlier discontinuation of antibiotics. We need to see the word is discontinuation and not de-escalation. So using PCT levels and following them up can help in stopping the antibiotics. That is very important. Use of PCT in one of the studies led to 4-day reduction in antibiotic duration in the septic patients. One of the trials showed 5% lower 28 days mortality with PCT guided treatment because of lesser side effects from antibiotics. Also, one study showed 2 days faster recovery in clinical response with PCT guided therapy. ProVAP and ProHosp trials documented significant cost reduction because they could reduce the antibiotic cost and less hospital or ICU stay, which led to much more cost reduction in overall picture. And ProAct studies also showed 1.3 days shorter ICU stay with PCT guided antibiotic treatment. So PCT can be used in different settings starting from primary care, emergency department, hospital wards, and intensive care. In primary care, they noticed reduction in antibiotic use significantly in respiratory infections. For emergency department, especially COPD and bronchitis patients, lower PCT values exclude bacterial infections and antibiotic use was prevented. For hospital wards also, antibiotics were discontinued early based on PCT based therapy. And in intensive care, PCT along with other markers and other symptoms lead to a better care overall. PCT has to be used in terms of decision making algorithm. So first we assess the risk, evaluate the risk of infection and pre-test probability. When the pre-test probability is low and PCT is less than 0.25, antibiotics are unnecessary. However, if the pre-test probability is high, we still give antibiotics and follow up with the PCT guided response. When the PCT comes down to less than 0.25 or decreases by more than 80% from peak, we can discontinue the antibiotic. This is true especially for the hospital, for the severe community acquired and some of the hospital acquired pneumonia. Now, there has to be low and high risk protocol based on the PCT levels and clinical suspicion. So, for low risk patients, PCT of less than 0.25 rules out infection from bacteria. In high risk protocol, initial antibiotics have to be given regardless of PCT, and we monitor PCT to guide the duration of treatment. The drop in PCT value by more than 80% suggests infection has resolved. However good and impressive it may look like, there are certain limitations for PCT use. One is there is insufficient data for immunosuppressed patients, including transplant, HIV, and immunomodulatory therapy patients. The guidelines are mainly derived from immunocompetent adults. So that is something we need to know. There are certain non-infectious causes when PCT will be elevated. These include medullary cell carcinoma of thyroid, the cells which produce PCT, major trauma, severe burns, cardiogenic shock, and after certain surgical procedures. These elevations may lead to unnecessary antibiotic use if not properly contextualized. PCT has not been well validated for localized or chronic infection such as osteomyelitis, endocarditis, or abscess formation. Also, atypical pathogens like Mycoplasma, Legionella, Chlamydia often produce relatively low PCT levels, and there may be confusion. Similarly, fungal and most viral infections will lead to minimal elevation in PCT, although clinically patient may be severely ill. PCT is eliminated by kidneys. So, if the patient has renal dysfunction, then PCT levels may be falsely elevated and may not clear soon. So, we have to take that with a pinch of salt, and we have to keep these limitations of PCT in mind while taking decisions. So, what is the future for PCT? PCT is likely to be a main source of our decision making, and point of care tests are needed which can give us quick result. There has to be a standardization for result comparability among different PCT assays, and PCT cost, the cost of test, which is currently around 5,000 6,000 rupees, has to be brought down significantly for its widespread acceptance. Now let's see how beta-D-glucan testing is useful for invasive fungal infections. So as we all know, polysaccharide is the most common component of the cell wall, and beta-D-glucan is among that. It is detectable in the serum during invasive fungal infections. There are various commercial tests available for beta-D-glucan testing. The performance of beta-D-glucan in hematological cancer patients showed 61% with single positive, 61% sensitivity with a single positive test, 91% specificity with a single positive test, and 99% specificity with two consecutive positive tests. And we also need to know that there are certain conditions like immunoglobulin therapy, blood transfusions, and antibiotics, which include cefepime, piperacillin tazobactam, meropenem, imipenem, cilastatin, coamoxiclav, and vancomycin. These all lead to false positive beta-D-glucan levels. If we look at the performance in various ICU patients, so good sensitivity and reasonable specificity for invasive candidiasis and less specificity for invasive aspergillosis. And when two consecutive tests are positive, the specificity increases significantly to almost 90%. So for ICU patients, beta-D-glucan are useful to exclude candidiasis and guide antifungal therapy decisions. For solid organ transplant patients, there is limited data. However, beta-D-glucan is useful to exclude invasive fungal infections in low-risk patients. And in hematological cancer patients, serial monitoring is recommended, and we have to interpret it along with the other criteria. Now let's discuss a little bit about galactomannan. So as we all know, invasive fungal infections cause high mortality, especially in immunocompromised patients. Early diagnosis is critical, but it is often difficult due to non-specific symptoms. And galactomannan testing aids to early detection of invasive aspergillosis. So galactomannan is a polysaccharide in aspergillus cell wall, which is released during hyphal growth. Enzyme immunoassay was approved in 2003 by the FDA. The OD index more than or equal to 0.5, generally it is considered positive, and monitoring twice a week in high risk patient is recommended. If we look at this, there is reasonable sensitivity, high specificity, and very good negative predictive value. But also there are some false positive rates along with this. When we send BAL galactomannan, it has got higher sensitivity compared to serum. The cutoff value is recommended to be 1 for BAL specimen, and the specificity is very high, up to 100%, and more advantageous in non-neutropenic patients. There are limitations for galactomannans as well. So there can be false positive similar to beta-D-glucan, beta-lactam antibiotics and other fungal species infections. Reduce sensitivity when we use concurrent antifungal therapy. Patient factors like in the first 100 days post hematopoietic cell transplant, there are higher false positives because of various factors. And immaturity of intestinal mucosa in pediatric patients may cause false positive results. So we need to know these limitations. Now a little bit about BNP and NT-proBNP as vital cardiac biomarkers. So in 1956 it was identified as atrial granules. Then it was noted that this atrial extract had diuretic effects. Then the structure of atrial natriuretic peptide was identified, and in 1998 BNP was discovered from pig brain, and hence the name brain natriuretic peptide. And later it was discovered that it arises from the atria and ventricles. When the atria or ventricles are stretched for some reason, the BNP is released. It causes diuresis and natriuresis, vasodilatation, inhibits aldosterone by counteracting RAS system activation, and it has got antifibrotic and anti-hypertrophic activity. In terms of diagnosis, in acute heart failure, if BNP is less than 100 or NT-proBNP is less than 300, these levels are used to rule out acute heart failure. For chronic heart failure, the thresholds are lower. And in terms of therapeutic applications, recombinant peptides like nasiritide and carperitide have mixed results, and sacubitril valsartan inhibits neprilysin and reduces NT-proBNP by 30%. So that is a useful marker to see the effect. And there are neutral results with biomarker guided therapy for the heart failure, chronic heart failure patients. So that's about NT-proBNP. So to summarize about all the biomarkers that we discussed so far, these are measurable indicators of biological states or conditions, categorized as diagnostic, prognostic, predictive or monitoring biomarker based on clinical application. Biomarkers enable early disease detection, early differential diagnosis and staging. The biomarkers provide objective measurements for disease assessment, treatment selection and monitoring therapeutic response. They are crucial for personalized medicine approach. And advanced technologies expanding biomarker discovery are needed, and multi-marker panels and AI integration is needed to improve the diagnostic accuracy and clinical decision making process. So with this, we end this session, and I hope you found this video useful. Please share it with your friends and colleagues. Please subscribe to my channel, and if you have any suggestions or criticism, please write in the comment box. Thank you so much.